Dr. Emma Watson here today. Dr. Watson is a 2020-2021 UK Harkness Fellow in Health Policy and Practice, a consultant medical microbiologist by background, and a senior clinical systems leader in Scotland. She's an expert in quality improvement and in medical education and workforce planning. Emma is Deputy Medical Director in NHS Highland, which is geographically one of the largest and most sparsely populated combined health and social care systems in the UK. She's also a senior medical advisor in the Scottish Government. In both roles, her focus is on developing innovative approaches to ensuring equitable access to high quality healthcare services with a sustainable health and care workforce, particularly in remote and rural areas. Emma has led a number of major change programs, including the development of Scotland's first graduate entry medical school. Emma previously held a post in the Scottish Government as clinical lead for the Scottish Patient Safety Programme, during which time she ensured quality improvement methodology translated from the development of health policy and strategy through to the implementation across the entirety of the Scottish healthcare system. Scotland was the first country in the world to implement a patient safety program on a whole system basis at a national level. As Director of Medical Education in NHS Highland, she focused on the delivery of high quality medical education as a tool to increase recruitment and attract young doctors in the region, as well as ensuring there is now an established program to encourage young people from the area to go to medical school. And during the COVID-19 pandemic, she has led the clinical response in her region and ensured that there was a whole system approach to manage the effect of the virus. So thank you so much for joining us today, Dr. Watson. You can take it away.
Oh, thanks, Hannah, and thanks for that introduction. I'm going to share my screen. Once I've shared my screen, I can't see any of you. So I've asked Christy and Hannah to let me know if there's any questions. And sometimes it's challenging, isn't it, to interrupt a speaker when they're in full flow, but I will have made some assumptions about the knowledge of my system that may not translate for you, and please feel free to interrupt for clarification. And Mark, I'm guessing you're now the real Christy. and that made me smile. So I'm going to share my screen. Hopefully that will work, and I will get going with my talk. Can I just check in that you can see my screen?
Yep, we can.
Yes, we can see it.
Thank you. So I'm going to give this talk from my perspective as both the Deputy Medical Director for NHS Highland, that's a board level position, and in that role I'm responsible for the acute care delivery across 4 hospitals. But I'm also going to refer back to when I was the Director of Medical Education and my role in Scottish Government as a Senior Medical Officer, which is an advisory role to the government of the day. So hopefully this will move forward. So I'll do some introductions. I'll talk about my conflict of interest and my sponsorship here. I'm going to try and cover rural health as a legacy, and it's I hope that is of interest to all of you. You know so much about rural health, but oftentimes when I'm talking to audiences, they really cannot conceptualize rural health delivery, and that I think is part of the challenge. I'm going to talk about the organisation of care delivery in NHS Scotland, and then focus on my health board, NHS Highland. I'm going to describe for you our challenges and what we've done, and hopefully that will be interesting for you. So I'm here supported by the Commonwealth Fund, who are based in New York. They're a foundation that really is trying to learn more about success in healthcare delivery, and they've got a real ambition for access for all. And I want to acknowledge my colleagues that I've worked with in Highland, and they're named there specifically, and Roger and Sarah Strasser, who are key mentors of mine and have been for many years. And TJ, his name is on there because without TJ, these slides would not look as beautiful. And he also helped me with some of my storytelling, and I was so grateful. And I'm really thrilled that he's also come because he has heard this before. But my big conflict of interest is I'm from rural Scotland. I grew up in a rural area. My grandparents were both, well, one was a head teacher in public schools in rural Highlands, and my other grandfather was a minister in very rural Scotland. So the context of rural is something that I didn't really know was different for other people until I went to university and started work. So you've heard about my professional aspects from Hannah, but in rural, we have a long held tradition of making sure that you know who we are as people, because who we are as people comes with us every day to work, and it influences what we do and our thinking. And we try, when we're meeting new people or starting meetings, to make sure we're checking in with who that person is and what's important for them today. So I'm here, as you've heard, from the Highlands of Scotland, Inverness, and I'm delighted to be living in Chapel Hill, working with all of you. I'm a daughter. I miss my parents. The COVID pandemic made that even more challenging. So it's years since I spent some quality time with my parents, who are getting much older. I'm a sister, I'm a wife to a colorectal surgical professor who I've uprooted and implanted in Chapel Hill without his clinical practice. And I'm a mom to 3 great kids, one of whom is stuck in Australia, worst places to be, I guess. And the other 2 are with me here in Chapel Hill. I've used the phrase consultant. I think that's in attending. And you've heard about my professional career from Hannah. But my career aim has always been to serve my community. And I think you will see that through the themes in my medical education, but also in the quality improvement work I've done. And even in a free point of delivery service, access is a challenge. And when I talk about affordability, it's affordability to the system. And the challenge is the lack of affordability make to how many people we can treat. And it's always about the impact on the patient and their family. So I want you to have a little read through these statements and have a guess of what year this was said. And this is from a pretty key document that influences care delivery in Scotland. And you feel free to unmute and shout out if you've got an idea. But maybe you're all a bit shy. So it was in 1912, and it was published in 1915, not 2015 is the typo I've recognised on there. And this was an excerpt from the Dewar report. And basically, it could actually still describe the challenges of rural healthcare delivery in Scotland, but I guess globally, actually.
It actually mirrors a lot of what Florence Nightingale used to say.
Yeah. And the depopulation is an interesting one because it's depopulation of younger people. But we are a net migration in Highland of older people who've come to retire. So Dewar was a politician, and I'll talk a bit more about that in a moment. But in Scotland, the history of our rural areas is sometimes much more important than geography, and it colours our rural population's perception of incomers, of people who they view who are taking an authoritative position, or people who potentially have power over them. And the power dynamic is a very interesting one to explore. And this is a picture of what would have once been a pretty busy, lively, crofting community. The foreground, there would have been housing, there would have been grazing, and more importantly, there would have been people. But in the sort of 17th, 18th, 19th, 20th century, there, so hundreds of years of history here of rich landlords exercising their power over that community. In the 18th century, they swapped people out for sheep because sheep were more profitable than people. And they uprooted communities and implanted them elsewhere. This has been very unsuccessful. And I think it's oft repeated and has never yet had a successful outcome. And so these communities were implanted to areas that they didn't know, away from their kith and their kin, without means of earning a full income to sustain their families. And that piece was deliberate on behalf of the landlords who felt that this would be good for these rural dwellers and that they would have to become much more entrepreneurial in their spirit. But actually, it still got legacies today on the health outcomes of some of our rural populations and the poverty in which they live. So I read you an excerpt of the Dewar report. This is the Dewar Committee. Dewar was a wealthy individual. He was a politician in the UK. He was from a distilling family. And he was very curious about the lack of data coming out of the Scottish Highlands on health outcomes. But more importantly, he was really drawn to the fact that there were very few deaths reported, and actually less than 50%, just about 50% of deaths in Highland were reported at the beginning of the 20th century. And this compared to about 2% of non-reported deaths in urban Scotland. So there's something definitely going wrong. So he went and he had a look and he took his committee with him, and I think he was pretty horrified. This was at a time where there was a national insurance levy being proposed to deliver health in the UK, and there was an expectation that everybody would be able to pay for that healthcare delivery. And it became very apparent to Dewar that the population in the Highlands absolutely would not be able to afford even the smallest levy. But apart from that, there were no healthcare professionals, there were no doctors, there were no nurses, and there was no access to healers. So he commissioned the Highlands and Islands Medical Service, which was the first free point of delivery health service in the UK. They recruited doctors and nurses. The first nurse was positioned in St Kilda in, I think, 1914, 1915, in the middle of the First World War. And the health service in the Highlands grew from there. But interestingly, he stated that exceptional measures needed to be taken in rural, and that an expectation that what worked elsewhere would work in rural was a fallacy. And I worry that we've forgotten that as we've progressed through the evolution of our health service. So rural health is important. All of you know that, but actually it's our rural populations that provide the majority of our natural resources. They generate our food, and without healthy rural populations, it's terrible for our economies. 50% of the population live rurally globally, and in high income countries it can be as up to 20%. And those numbers vary depending on which definition of rural you use. And I was noticing that in the US you can get that level down to 4 or 5% depending on the definition of rurality you use. But it doesn't get us away from the fact that having healthy rural populations is important. How those populations view themselves is key, because it influences how they interact with services that are provided. And actually there is an expectation, both consciously and unconsciously, that care will be different in rural communities, and it's always on the metric that it will be worse. So our populations rurally are older, sicker, poorer. We know that, we live and breathe it. we are often dealing in rural healthcare settings anyway, from initiatives that have come up from urban settings that make complete sense to them. And what works in urban will often not work in rural for a multiplicity of reasons. But I'm really curious that often urban areas do not want to learn from rural, because actually rural initiatives very often work well in particularly fragile urban settings. The financial model for urban that seldom works for us in rural, not least because we have to pay our staff differently. We've got different economic challenges that both in our communities and that draw our clinicians, and one that we face regularly is that the schools in our rural communities are oftentimes poor with, so our healthcare workers have to send their children away, which is culturally not something that we do in Scotland. So that's a challenge. And I'm really curious around the how it feels for rural communities to have incomers looking after their health. And I often described it as missionary work, and the way those clinicians interact with rural populations, all from a sense of good and well-being, but how does it feel? And so I was delighted to find a paper from Force, who works in rural Norway, about geographical narcissism. And actually it's a fascinating paper, and if you haven't read it, I would commend it. And Force describes the complete paradigm shift that they experienced moving to a rural setting, and how they had to completely change their perspectives. But also rural communities are often the recipients of healthcare providers who don't make it elsewhere. And there's a belief that anything is better than nothing, when actually, particularly in a small community where there's no peer review, that can be incredibly detrimental. Urban areas have their challenges too. Overproduction, definitely over provision, and I see that in my country, but I see it in yours as well. But more choice than people can make sense of, and more competition than is useful. So both sides of this coin are challenging. So I'm going to home down into Scotland, my country. I don't have a pointer, but I live in Inverness, which is, as you see there, the V in the headland, two headlands coming together. Scotland is a rural country. It's difficult to get around. The majority of the people, the image here of the darkness is Scotland at night from space. For just over 4.5 million of our just over 5 million population live in an area that is 40 miles deep and 100 miles long. And all of our services are more or less delivered there. The infrastructure there is incredible, beautiful new motorways, fantastic new hospitals, great entrepreneurship and industry. The area I cover is that area in darkness. If you look to the right of the headland, those dots are not islands, they're oil rigs. And actually there's probably more people on some of our oil rigs than live on some of our islands. The rural classification in Scotland, that we worked a 6-fold rural classification, which is very different from the one you use. But again, you can see that the Highlands of Scotland, the yellow area largely, are pretty remote and rural, with accessible rural, the next biggest area of land, and very small areas, but with very intense populations in the Central Belt. I put this picture in because that's what our landscape looks like. And more importantly, this is a main road. This is the main road that goes from Inverness to Applecross. And interestingly, in the summer, it's often chock-a-block full of RVs who are trying to go both ways down this road. That is one of our true challenges. In the Highlands, there's just over 60 miles of dual carriageway, so the infrastructure is poor. So the Scottish National Health System which is different from the English National Health System and from the Welsh and the Irish, did get its roots from the evolution of the UK-based health system, which was established in 1948. So it's quite an old public health system now, built on the principles actually of innovation of the Highlands and Islands Medical Service. And that was great for the broader population base, but it's probably where we've seen the improvement in healthcare delivery fall in rural areas, because that exceptional element was no longer key. It is publicly funded. I think you all know that. Scotland has a devolved government from the UK government. Not all factors are devolved, but health is. And in Scotland, 40% of the Scottish budget is spent on healthcare delivery. And that's health and social care. So it's potentially bigger than just health. And our social care covers the social services, I think you describe it here. It's free to everybody, so nobody pays. That includes pharmacy. All prescription drugs are free in Scotland. All eye exams to all aged people. And there's a small co-payment for dentistry. That covers primary, secondary and tertiary care. Some quaternary services that are not available in Scotland, the Scottish Government pay for the population to go generally to England to receive that. In Highland, our closest tertiary hospital is in Aberdeen, which is about 110 miles from Inverness and just over 220 miles from Wick. So that's quite a long way to travel for your tertiary care. A very small level of private practice in Scotland generally, less than 2%. And the majority of that is delivered in Edinburgh or Glasgow. We're divided into territorial health boards, which deliver care directly to patients, and special boards, which look after the functions of the national health system. And those functions cover education, laboratory services, ambulance care, quality improvement. And the National Health System in Scotland is the largest employer in Scotland. And as such, it has a really key role in the economy. Now, the health system isn't necessarily how we've delivered into operational units. For me in Highland, which is number 19 and number 18 on your picture, we're quite lucky. Our integrated joint boards follow our council boards, which would be your counties, and they're pretty much just 2 operational units. The rest of the Scotland acute care is delivered in partnership across a multiplicity of integrated joint boards, and that's quite a culture change for us. And the aim and the ambition is a really good one, which is to integrate care and to increase anticipatory care, to improve population health, to reduce impact on acute care. But as all of you know, that's a challenge, and it's a challenge because of timelines. Great investment now in social determinants of health are not going to make an improvement in acute care delivery for often many decades to come. But actually we are not in a position to double run. So it's challenging. It often looks and feels like failure. We're block funded, so we get a sum of money, and you can only work within that sum of money to deliver the health and social care that your population need. For Highland, that has been a challenge. And there's a new innovation coming, which is our national care service. So that's going to look to disrupt this landscape again, remove, I think, the power base from acute care hospitals, because we did not manage to make that shift with the evolution of integrated joint boards.
Emma,
So
can you just talk for a second about who's on the NHS health boards? Like, what kinds of people are there?
Yeah, so if we go back to the health boards are statutory functions, and they have a chief executive officer, a chief nurse officer, chief medical director. They have finance officers, And they also have a social care lead on the health board. And they have non-executive directors who come from the local population. The key aim of that board is to provide financial balance and high quality care to the population. If we come to the integrated boards, that's a very different picture. And they are boards that have representatives from health. But they are generally made up of local councillors who are making decisions about the healthcare delivery, both across primary and secondary care, and about social care. And I think one of the reasons this hasn't necessarily been successful is there wasn't a huge investment in the board development to understand the right questions to ask and the pushback to give. And we describe in Highland that we are lucky because we are an integrated board with health as the key leader. Lucky for who is what I would have often pushed back, because we did not really change. We didn't change the power dynamic. We didn't change the conversation. And as such, we didn't necessarily make the changes that we needed to in the social determinants of health. It's interesting working with 18, Argyll and Bute, who are a body corporate model, and the discussions in that integrated joint board as the senior clinician are very different, and they are much more interested in investing in the local population and in factors out with health. The big challenge is how we then communicate that to the community, and it seems really incredible for me to say this to all of you who are looking at rural hospital closures, but is it that we actually need a hospital, or is it that we need a health hub? What is the function that we need in that community to generate health rather than respond to illness? So it's very interesting landscape. The National Care Service will take this a step further, and actually the balance on the boards will be very, very low in terms of healthcare providers. And so I think the governance around that will be really interesting, and the community engagement and implications for people.
How do the boards get community input? I guess that's what I'm trying to get at.
Yeah, so not very well, I think, is the answer. And if we go back to the health boards, the non-executive directors are supposed to be there as the voice of the communities. Any of you who had an interest in and looked at the Scottish press would just get a real feeling of despair from the community that their health service is not responding to their needs. I've been intrigued by the community health needs assessments that the local hospitals here do. We have a board-wide community health needs assessment that is delivered by our population, our public health team, with a small amount of consultation with the public on the finished article, rather than drawing people in at the beginning and understanding what is important for them and what's important for their communities. And also we're in quite big, chunky units. So what works for Inverness doesn't necessarily work for Thurso, and it almost definitely doesn't work for Skye. And that is magnified across Scotland. So it's an area that we really could do better on. The elected politicians are also trying to have that communication, but the health juggernaut really does carry on its own mission. The integrated joint boards just has better community engagement because of the councillors who are on those boards, and they have lay reps. But again, because of the I think it's probably pretty exhibited power dynamic that plays out on these boards, those communities often feel underrepresented. It's something we actually don't do very, sorry, I'm just laughing because I've just seen that you're Christie wannabe, that we just don't do well on. And it's something I think the US system seems to do much better on than we do. I've put in a slide on performance metrics, and because although we have free at point of delivery health, our performance isn't great. And that's a kind of outcome of rationing, I suppose. But many of the clinicians here in the States would be horrified that we have a 31-day time lapse from a recognition of a diagnosis of cancer and a decision to treat, and we have a 62-day pathway to start cancer treatment from point of referral. I think here you're looking at 14 to 21 days. In terms of routine surgical procedures, we have a legal obligation to see people within 18 weeks of referral. 18 weeks, that's quite a long time. Many health boards don't meet that, and following COVID, we are so way off the mark of that. We're talking about waiting lists of years, not weeks. So one of the downsides of our wholly publicly delivered health system is that there's no pressure release valve. There is nowhere else for people to get their care. And so actually in terms of equity, it's not great, because in amongst these descriptive statistics, there are people who know how to play the system, who will get seen much quicker, who will use their levers, whether they be political or relational, to get their treatment in a much more expedited way. So free at the point of access doesn't deliver necessarily to equitable access. I'm going to focus on Highland a little bit. We are the largest territorial health board in Scotland. We're 20,000 square miles from one tip to the next, with a pretty sparse population of 310,000, and a third of that population is in Inverness. That gives you an average of 15 people per square mile, but in some of these hinterlands, it's one. I would like to say less than one, but that's a bit difficult. We've got 40 inhabited islands that we have to deliver care to. And as I've alluded already, we've been integrated with social care since 2012. And we would say we were still early in that journey. And I alluded already that we haven't necessarily got the power balance or the relationships right in that integration. And we, instead of health, learning from social care on how to balance risk and put population needs first, we've become a very dominant health model who've taken the care service into our risk model, which is we are pretty risk averse and resource heavy. So in terms of size, we're the size of Belgium, which equates a bit to the size of West Virginia. The red H's on your screen are our acute hospitals, of which we have 4. The blue hospitals, I think the closest analogy here would be specialized nursing homes. They don't deal with young people at all. They are generally nurse-led or family medicine doctor-led. And the age of admission of patients is generally in the early 80s and older. So we don't use these facilities well, with the exception of Skye, which runs itself as an acute care hospital for the population of Skye, but it doesn't have the resource underpinning that. So we're pretty grateful to the GPs there who go above and beyond. So we have challenges in Highland of delivering over a huge geographical area to a small resident population. Sustainability of our health services across primary and secondary care is a challenge. We've got significant inequalities. If you live in Caithness, you have a local hospital, but your access to specialist services is either in Inverness, Aberdeen or Edinburgh. That can be a 3, 6 or 9 hour drive, depending on which of those you go to. And that influences people's decisions about accessing health. I've referred already to our pretty limited internal communication structure. Our population swells during the tourist season can go up to about 1 million, which is a challenge for us. And it's a particular challenge because we don't necessarily have good mechanisms for cost recovery. So when you're free at point of access, you don't have a way of making sure you've recorded people's payments before you deliver them care. So we kind of lose money on the people that come to visit us. And the Highlands is on people's bucket list. And people come here when they're to the Highlands for their holidays, when they're quite old and infirm. And we have a lot of people die on their holidays here, not necessarily because they're doing really courageous, heroic stuff, but because they were very old and that they were end of their life and they wanted to see where their ancestors came from. And that's a big challenge and one that other parts of Scotland don't have. We've looked to ways to recoup money from different taxes on hotels or other businesses locally, but they don't want to engage around that. And our demographic change, as you can see, where people come to retire to the Highlands, which adds again to the challenge of who we recruit and the type of people we recruit and the patients that we care for. These slides I'm going to race through because they just say the same thing, and I'm taking longer to give this talk than I anticipated. I apologize. You can see from our health conditions, it's pretty similar to what you would see here. Cardiovascular disease, cancers and mental health issues right up there in the top 3. Interestingly, that's not necessarily how our workforce is organised. The impact of all of these things in Highland has been really challenging. We have been actually a bankrupt organisation for many years in brokerage to the government to be able to sustain care delivery. And that's because we spend more than we get. And for about 6 or 7 years, the mission statement in Highland was one of quality at all costs. And actually, just concentrating on quality did not yield financial benefit. You actually have to be intentional about finances alongside quality. And you know, I would describe to people that financial performance is a pillar of quality, but many clinicians find that difficult to engage with. We had very challenging recruitment, significant cultural challenges. Many people that work for NHS Highland have worked for NHS Highland for all of their professional life and have certain ways of doing and thinking. And often the board viewed disagreement from clinical teams as disengagement, when actually it's pretty active engagement. They just didn't like what was happening, and often for good reason. Very poor financial control, 4 chief executives in 3 years, and a real lack of clarity of mission about where the health board was going. But we definitely had bright spots, and I was lucky that I was at this point in my career the director of medical education. And what we found was that our staff across all staff groups were super engaged on education, and they were super engaged on clinical quality. So that at least gave us somewhere that we could go to kind of reverse the challenges that we were seeing. So so we looked to the evidence base. We reached out to our kind of national and international partners to ask, what could we do with this? We've got a failing health service. We're financially adrift. We can't recruit. But our guys love quality and they love education. What can we do? So we decided to build a vision of Highland around educational excellence. So come and work in Highland and be the best educator you can be and deliver the best clinical care that you can. And we built a collaborative around that internally in the health board, in partnership with our GPs, as well as our secondary care providers, as well as our nursing teams. And we were really intentional that we wanted to grow our own workforce, but this would take a long time. In parallel, through our partnerships with the Strassers, we engaged in a research project from the EU called Making It Work. And although it was EU funded at the point of starting, only Scotland and Sweden were EU members. Now it's just Sweden. So it was a collaboration with Canada, Iceland, and Norway, Scotland, and Sweden. And we were looking across all public sector services. And the big challenge for all of us was that there was just not enough people. So everything came back to how do you recruit and retain a sustainable workforce to then go on to deliver a sustainable health service, education service, police service, fire service. And the other thing that we recognised through working together was that many of the services in the rural communities were built around niche interests of the providers that came, rather than what the populations actually needed. And that goes back to George's question about how were we engaging with the communities. We just really weren't. And any engagement we had was nominal and not intentional, and it definitely didn't yield differences. And that lack of joined up work with the communities was really important. And at least now we recognise that. I don't know that we've actually got on top of it. So as an output of that, Making It Work, what it said was you need to work with your community, you need to engage with them, listen to them, understand their needs, align your services to those needs. You need to engage them around your recruitment, you need to engage them around your retention, you need to engage them around your care delivery. And I think one of the sad things for me is that research, whilst given lip service to, it sits on a shelf often. So we were really determined in the education field to do this and work to this cycle. And we also, in parallel, had some action research going on in our islands, looking at who was there, what health did they need, what did the community view as important, how would the community view a different provider from a doctor, how could we work with them to ensure that they felt confident and safe with maybe a community health worker or a rural support team who was based elsewhere. And actually the learning from that work was that early engagement with the community, understanding their challenges, working with what they needed, having them engaged in the training around some of the different healthcare professionals was really successful. But again, we've done it in pockets. We absolutely have not systemized that, but it was a pretty powerful piece of work for us. This slide is one of our islands, and this is a ferry that comes once or twice a week. So actually the community health worker in that community who's been trained as a first responder is really essential to the ongoing health. So what did we do? And people talk about pipelines, and I don't think Erin's still with us. And she gets very frustrated by the discussion of pipelines, I know, but I put in a picture of a leaky pipe, because actually that's the reality is no matter what pipeline you put in, you will lose people, whether it's because they didn't want to come in the first place, or they want to go and experience something else, and you have to build that loss into your equation. So going back to our teams who were disenfranchised, disengaged, but loved educating, what could we do? So we started a program with high schools, and the prompt was that only 3 high school graduates from our Highland region, that large area that you saw, went to medical school in 2012. Now, in terms of interns, we have about 30, so we were definitely not covering our bases on that one. So we worked with schools, we worked with communities, we worked with parents to try and understand what was going on there. Why were they not supporting their kids to medical school? And there was a negative spiral. So repeatedly kids had applied and not got in. So we had to work with universities as well to say, look, our kids are important. And some of them will come and stay and work with us. What can we do? This is a long game. After the first cohort, it was really interesting. We had to debrief the kids because many of our clinicians would say, do not come into a career in health. It's really arduous, you won't enjoy it. So we debriefed the kids and said, you'll hear this, why do you think that is? What could you do differently? And then we also had to work with our colleagues and say, let's understand and explore that a bit more. What can we do to help you change your perception? So this has been quite a successful program. So in 2013, we doubled our numbers going to medical school. And the last year we have figures for is 2018. COVID has really got in the way of us getting the figures out, but we believe it to be 40 in 2019 and 20. But to go from 3 to 26 in a period of 6 years is good and very nearly being covering the bases that we needed for interns. So we grew our numbers, we grew our funding, we got highly recommended by the GMC, that's our regulator. We were a place for the graduate medical school, which may not surprise you all as I commissioned it. But we also expanded into different types of provider, physician associates. They were not happening in the rest of Scotland. And we started looking at what else could we do that was innovative for other providers. And we started longitudinal clerkships for pharmacy. We were the first provider for longitudinal pharmacy clerkships in the UK. We historically had worked with one university, Aberdeen, so we were only accessing 20% of the medical students in Scotland. So we worked in partnership with all of them so that we could grow the numbers that wanted to come, but also our clinicians came from all across Scotland, and that gave them a link with their alma mater. They were alums of these other universities, and they understood how those programs were set up. So we were able to engage many more educators, and we worked with NHS Education for Scotland. That has been a challenge. They are very biased against rural, and I'm hoping that in the future that will change because of some personnel changes in that organisation. We worked with our medical students in different universities, sponsored them to host conferences with us, and we shared our balanced scorecards. We thought everybody got greens for most things, but they didn't. And we hadn't been letting people know that coming to learn in our rural area, you were going to get really good experience because you'd be in small groups and you would have preceptors who knew your name. So we developed that work within board rather than bleating that NES didn't give us any residents. We grew our own. We created our own programs. We looked to what the young doctors wanted, which was a bit of time. In the residency programs in the UK, there is no time built in for your own development. It's just service delivery badged as education. We delivered local CPD for our educators, and we brought primary and secondary care together. So that had another important factor of knowing each other, which for care delivery for patients was really, really important. We established a mentor scheme that was funded by the Health Board for those delivering education, but also clinical care. And we started having biannual medical education conference with international speakers. So our educators felt invested in. I progressed to be the medical director for Acute during this time. And I realized that my leadership team from education would actually make really good clinical directors. So I brought them with me, which was good. So the impact locally in Highland was I think impact was impressive. We increased our education budget by 50%. So it went up by a couple of £1 million, which is about $4 million. We also saved at the same point $4 million per year in locum. So we had much more money to invest in staff, in well-being, in growing new positions. we took on values-based recruitment. This was a big leap for us. We took anybody, and it didn't really matter what their credentials were. We filled gaps. We actually started to have the courage not to employ. And that actually, once we'd got through it and got some quality people in place, increased our recruitment to our more rural areas. And we now have fighting competition for some of those posts. We worked on what our recruits needed and what our established clinicians needed to stay. So we developed posts that were had more free time so that the clinicians could go and work abroad, delivering humanitarian care. We looked to what we could do to support their spouses and their families so that they felt that invested in as well. And we had the bravery to offer people quite long tasters, come and work with us for 3 or 6 months on a see how you feel at the end of it basis. And we did that across primary and secondary care, and most people have stayed. And those that haven't stayed, they wouldn't have stayed anyway. So actually it's felt really positive for everybody. It was a success that they left. And we worked really hard with our rural hospitals. Although we were a system, we didn't operate as a system. We found that the rural hospitals were pretty much left to their own devices before this piece of work. They hadn't got support around recruitment, they hadn't got support around the education delivery, and they definitely hadn't had support around improving the quality of care. So we set an ambition that we would be one hospital delivered across 4 different sites. And that helped us in COVID. I was pleased with that. I was lucky to be able to take my learning from Highland to a national level. In Scotland, remote and rural is garnering real political capital. And the slide I showed you of the 6-fold rural classification would be illegal to show in Scotland because it has Shetland off the coast of Orkney, which many of you know is not true. It's much closer to Norway than it is to Orkney. And in fact, you now have to show maps that are absolutely where places are. So one of the benefits of working in Scotland is that we're very close to our civil servants and to our ministers. That can be positive and negative. So they're very close to you, and they can feel nothing about the health minister phoning you up and asking you why you have made a decision that has yielded unpopularity in the press. But actually we decided to take it as a gift and share with government, with ministers, what had been successful for us in Highland, what might not yet have delivered, but was definitely bearing fruit, but we needed more help to make it better. And in this slide, the pipe is the one that traditionally happens, which is people from big cities being piped up to rural communities where they wouldn't stay. And we were able to describe why that didn't work and why it didn't work for the communities, it didn't work for the clinicians, and it definitely didn't work for the government purse, who also provide free education for clinicians in Scotland. So unlike in your country where you can leave medical school in hundreds of thousands of pounds of debt, that isn't the case for us. So our levers are different. And the best lever we have is recruiting from a rural population. So we followed the same plan that we had done in Highland. And we were able then in a position to commission a new graduate school. The first class graduates in 2022. It's been incredibly successful. The students are absolutely committed to working rurally. They're a very empowered group. They're very vocal on social media about the essential need of equitable access to care in rural communities. And they're a super articulate group. In Scotland, medical school is traditionally an undergraduate endeavour, and graduates have to go through an undergraduate programme, but by able to take graduates and have a different learning model for them, we've really, really benefited as an educational community, as well as our populations will benefit from them in time. We invested in bridging programs with our universities. This was not popular. Why would you spend money on kids that need input when you have more than enough applicants from affluent public, private, what we would call private school, and I don't know what it would be called here, paid for school, to come into your medical communities and medical schools. Why would you take kids that need investment in the beginning? But actually, one of the kids from a rural area in the bridging program who would not have been accepted to medical school, her grades leaving high school were not high enough, with the investment of that year, has repeatedly now been the highest performing medical student in Scotland. Now, she would not have got a look in, and she is committed to rural. She will go back and work in a rural community. We had to fund the universities to increase diversity. I am speaking here as a civil servant, not as a fellow based here in a university setting. But universities are big business, as you know. In the UK, they tried to shield the reality of that. And these great big organisations that were rich as Croesus would not be investing in their population. So something about building on that going into the future of their social accountability to the communities they serve. But, you know, we're back in a very transactional relationship with universities on, we will give you X much money if you give us this many kids from rural areas, but you need to deliver them in a way that they don't feel special in a bad way. And we increased training places and training time for general practice and rural areas. So traditionally we had 250 residency places for general practice family medicine in Scotland. We increased that boldly to 400. Everybody laughed because we didn't fill the 250 places we had. But there was a real intentional communication strategy around that with our medical students and young doctors. And now we fill those 400 places. So there's something really important about using the evidence base to take you to where you want to be. COVID-19 has got in the way everywhere. This is one of our dual carriageway roads in Highland. I don't think you can quite see the other 3 roads, but the one in front of you. This could be any time from November through to April. We have pretty unpredictable weather, and it gets worse the kind of higher you get. And this is the main trunk road that takes you to Edinburgh. And that's how we felt in COVID. We felt a bit cut off. We felt out in the cold, yeah. So these are our hospitals. You can see that we have the oldest hospital estate in Scotland. Starting from the left of the picture, that's the Belford Hospital in Fort William. That's about 80 miles from Inverness. It's got 30 beds and no ITU. The second hospital there is in Caithness. It's got 50 beds and no ITU. And that hospital there, the square one, is the Lorna Isles Hospital in Oban. It's about 250 miles from Inverness and has 60 beds and no ITU. And then the one to the far right of the picture is Regmore Hospital, our main hospital, which has 450 beds, so still small. And pre-COVID had the 7-bedded ITU to serve our whole region. This was challenging for COVID. So what was it that we were to do? So we had to completely reorganize. We absolutely had to work in partnership with our rural system hospitals and feel like a system, feel like a single entity. We spoke with them on huddles every day. We spoke across the acute Highland sector as a collective every day. We wanted to ensure that everybody was informed at the same time and had the same access to clinical protocols, PPE, treatment. But we quite quickly realised that we could care for the COVID patients in Inverness, and we could maintain our clinical services in our rural hospitals. So they all had operating theatres and they all had access to ventilators. So we actually transformed our delivery model so that our elective care was delivered in the rural hospitals, which made it very attractive for clinicians to go and work there. And Regmore became our COVID hospital. That was good. I think it had a good impact on our community. We have less of a waiting time, believe it or not, than the rest of Scotland. This is our outcomes. If death is an outcome for COVID, And this is the Highlands and Argyll and Bute down at the bottom. Highland is the only one in the bottom few that serves a city. The next city to us is Aberdeen, and their outcomes are up here. So I think you could see that we performed quite well by reorganising early doors and working differently for our population. These were our vaccination rates up to the end of June, with I think pretty enviable vaccination rates in our older population. We're still not getting far with our younger people, and that's why we've had the fourth wave of COVID in Highland. But actually what we haven't seen is associated hospitalizations, because our vulnerable populations are fully vaccinated. So we were pleased with our performance in COVID. It was a very challenging time, but it has a really positive impact on us as a health system. Going into the future, Highland, I think, is pretty healthy. We came into financial balance in 2020. We recruited 50 providers to the acute care sector during the time of COVID. We filled many of our primary care physician vacancies, and actually now have a reputation for being an organisation that cares for its team, that understands their needs, and will do whatever we can to make their working life positive. We are not perfect by any manner of means, but it's definitely getting there. And thank you for your time, and I apologise that I actually took up the whole hour talking to you. So I'm happy to take questions, and I'm really grateful to you for listening to me, and I hope it was interesting.
Thank you so much, Emma.
It was very interesting, Emma. I just had one quick question. One of the big problems we have here is bypass. Where local rural folk go to the big city to get their care, going around the local hospital. Is that even possible in Scotland?
No, it isn't possible, and actually that's a that is just not a thing that would happen. So if whatever your illness, you turn up at your local hospital. So if you've got an aortic aneurysm that is going, you're taken initially to your local rural general hospital for assessment. Now those hospitals, the highest level of technology they have is a CT scanner. They definitely don't have any facility to operate on something like that. They only carry 4 pints of blood in the blood bank. So actually, when we're talking about equitable access, it's a problem. But also for your hip, you would be seen in an outpatient clinic in your rural hospital by a provider in our health board from Inverness, and you would join the Inverness-based waiting list. Once you get to 18 months on the waiting list rather than 18 weeks, you get into the pool that can go to the National Treatment Hospital, which is based in Glasgow. And there just is no legacy of people bypassing local hospitals, either for elective or acute. Does anybody else have any other questions? I hope it was interesting. And Ariana, I was keen to hear what you thought about the distances our population will travel. When you talked a couple of weeks ago, we were talking about distances of 30 miles being far, whereas we routinely ask our Highland population to travel over 100 miles sometimes for care.
Yeah, the range I saw for the US South was something like half a mile to 60 miles. So not nearly as extreme as what you've got in the Highlands.
And actually for access to tertiary level care, you have to go considerably further. So in Inverness, although we're a secondary care hospital, we have a couple of tertiary functions, but they will be lost to us because of recruitment. So the key one there is our renal unit and the dialysis unit, because we don't have the vascular surgeons to maintain the fistulas.
So you don't have for-profit dialysis providers, like DaVita is the big one here in the US. So, okay.
No, there's no for-profit provider generally in Scotland. We have, I think, 3 BUPA hospitals, and they're based around Glasgow and Edinburgh, and one other private provider, but they're staffed by providers from the National Health System on an ad hoc basis. They're not employees of those systems, but care like dialysis would not be provided by any of those hospitals. It's so different, isn't it?
I'll have to follow up with you separately because I'm actually planning to be in Scotland next summer. So,
oh, fantastic.
Yeah.
Oh, that would be great, Ariana. Hopefully we can coordinate at a time when I'm back.
Yeah, it would be probably a bit of a trek because I'll be in Edinburgh. So,
oh,
yeah.
And it is interesting because it's further from Edinburgh to Inverness than Inverness to Edinburgh, or so it comes across in any conversation you have with the central government and central providers. They would, they thought nothing of the fact I traveled to work in Edinburgh every week, but they would never come and visit because it was so far. So Hannah, back to you.
Yeah, well, thank you so much. I think we're a little bit past. I know some people said they had to leave. People have noon meetings.
I'm so sorry that my time management went wrong.
No worries. I think a couple people said they might follow up with you as well, so you might get a couple emails. Yeah, this has been really great, and we'll have a recording up on the website if you want to look back at it, or if other people are interested.
And I just got your message telling me we're out of time. Sorry.
Oh, no worries. I was just trying to maybe give you a bit of a heads up. That's okay.
So lesson to self, talk well.
Okay.
Thanks, Emma.
Take care. Bye. I'm so sorry I overran.